format. And
good evening, sir.
Good evening, Rakesh.
Yeah.
All
Hi,
set.
Rakesh.
Fine, sir. Going on.
Rakesh, your clinics are very popular. Huh? All our students are joining.
It's going on.
Yeah.
When does he do it? Kuthe, where and when?
JJ.
Okay.
Started doing online now, actually.
Acha.
Yeah.
Oh, so you must send the link. I can ask my students to join. कब रहता है?
अभी तो सर Wednesday को है.
Okay.
Wednesday 4 to 5. Just a case presentation, some discussion.
Send the link. Send me the
Yeah,
link.
yeah. Best of sir. I'll say.
So the clinical science thing you are not doing now, Rakesh?
Yet to start, sir. This Thursday now.
Okay.
Tuesday meetings have started.
Yeah.
So now Thursday I'll start.
Yeah. Tuesday meetings physical.
Yeah, physical. Last couple of weeks we started.
8:32. We can wait for 2-3 minutes more. 8:35 will start.
Yes.
I think we can start.
Sir, wait, sir. A few minutes.
Okay.
Joining in.
I think they're joining.
Yeah.
Okay. So this is what number webinar आता तुमचा Thursday वाला? 20, 25, 30 कितना हो गया?
No, more, I think.
More, sir. Touches around 100.
Really? How? When did you start?
No, the webinar number is asking. How many have we done? How many have we done?
Weekly, sir, from 18th of June.
From 18th of June. Oh, so it's almost
26, 30, around 30, 35. Yeah.
Yeah, even the Tuesday ones also, I think they started a little earlier, maybe around the same time.
But this Tuesday was brilliant. Huh?
What was it this Tuesday? I
think neuromuscular, clinical, and and histopathology. Absolutely brilliant. I think Shripad is really choosing the topics very well. Yeah.
He's doing it fantastically. Alone, everything.
He, वो हर एक speaker को पहले भेजता है letter, ये वो उसका. He's really getting the thing done.
He's very, very methodical in that.
Very methodical. Yes.
Chalo, let's start, Rakesh, I think. Yeah.
Yeah, we can start, sir. People will join.
Yeah.
Okay.
So, good evening, everyone, to yet another edition of the Thursday evening clinics. And today we have a special clinic. We have Dr. Sudhir Kothari, who is the founder of the FINE Foundation. And also, as you know, is a very accomplished person in vertigo and a very good teacher. So he's going to tell you about the history taking, the maneuvers, and the practical aspects of vertigo that each neurologist must know. So I'm sure you'll enjoy it. So welcome, Sudhir, to your own creation, if we could say that. Yeah.
The creation is.
Do go ahead.
I'm going to blame you equally 1/3 for it. And now, of course, only Rakesh and Sripad and all are crooks in that. Everybody. But thank you. And it's a pleasure to address the students here. Always, I mean, it's easier to do a talk for consulting neurologists than for students because students ask much more difficult questions. So let's see. I'm going to start sharing my screen. Okay. If the sound or anything, if there's a problem, let me know, or the video, Mansi. Okay. So I'm going to try and give a simplified approach to vertigo and dizziness. I'm just going to first go over what is the history. I spoke to Rakesh in the morning. So how the history should be taken, how to distinguish between central and peripheral, and amongst the peripheral, the most interesting and the most important one, BPPV, how to diagnose it and treat it. One very important sign which is often not been highlighted enough is the head impulse test, which I'm going to talk a little bit about. So I hope to cover these 3-4 points. Let me tell the story of this 65-year-old man. I'm going to begin with 2 stories. So this is an old patient of mine with stroke. He was on aspirin and telmisartan, and one day he woke up feeling dizzy and unsteady, and whenever he tried to get up, he was feeling dizzy. So he called up his GP, who immediately told him, "You go and get admitted." So this guy came to the casualty, and the CMO was wondering why he's admitted, why he's sent for admission, because BP was 130/80, pulse 110, there was no neurodeficit. But on trying to stand or walk, after a few seconds, he would feel dizzy. So he asked me, do we do an MR angio? Do we do? So I said, no, check his standing BP. And that slide is missing. His standing BP fell down from 130/80 to 90. So he had postural hypertension, and very rightly the GP had suspected GI bleed. So when you have occult GI bleeding, the first sign may be postural hypertension. You may not. He got melena and he got hematemesis things only later. But if this had been missed, the guy he required 2 or 3 pints of blood. So remember, when somebody comes with postural hypertension, you can get dizziness, and it is not always what we think that the person should say, I feel darkness before the eyes. They may get actual spinning vertigo. One of the reasons thought for this is thought to be that the vestibular cerebellum is particularly prone for ischemia, and therefore with low blood pressure, you may get actual vertigo and not necessarily just darkness. Recurrent attacks of brief vertigo for the last 3 days. There was no tinnitus or deafness, and he showed the GP, who gave him one of the typical anti-vertigo drugs, the combination. The boy improved and went for a picnic, but 3 days later, the picnic got over, both for the boy and the GP. So you could see that now he's getting nystagmus. But this was not just nystagmus, he also had finger nose ataxia. On the right, he's got this ataxia. So left side was okay, but I'll show it again. Left side was all right, but right side he had this ataxia. And what he had was a midbrain infarct. So just because the guy was young, he had no hypertension or diabetes, and only vertigo, the GP thought it must be simple ear vertigo, but no, you have to be careful when there is first time vertigo. So what typically happens, a dizzy patient, as it is, he's having dizziness, and then the doctor takes him for a ride. So you go and tell the doctor, I'm feeling dizzy, and what happens? The doctor does into bracket examination, because you should know what is the neuro-otological examination. Most people don't do that. And he asks for an X-ray cervical spine. Then the X-ray comes back. Of course, usually it is spondylosis is reported. So then you put on an intelligent face and say, see, I told you it is spondylosis, and then give some drug. If the radiologist is new, or if bad luck say you get a normal X-ray cervical spine, then go and check the blood pressure. If the BP is low, you call it, I think it's due to low BP. If it's high, you say high BP. If even that is normal, then what do? Then go and check the patient's age. If he's old, you say probably VBI, vertebrobasilar insufficiency. If he's young, then you have a problem. Then you say there's some problem with the inner ear fluid. You don't say what problem there is, just some problem. And final step, of course, you diagnose it as vertigo and give the patient drugs. So remember what is being done. A patient who's saying I'm feeling dizzy is called, given the label of vertigo. So I have lots of patients who come to me and say, what are you having? They say, I have vertigo. So I tell them, what do you mean by vertigo? They look at me. You don't know what is vertigo? I've got vertigo. So vertigo people think is a diagnosis. It is not a diagnosis. It is a symptom. And that too, it is very wrongly used. So now the Barani Society, which is the prime society for all these neuro-otological disorders, they have laid down criteria, what to call dizziness, what to call vertigo. For example, vertigo is a false sensation of movement. If the person does not have a false sensation of movement, if he just feels disoriented, that is not vertigo. That is to be called dizziness. But when the person feels he is moving or the environment is moving, then you call it vertigo. So typically it is spinning, but not always. And there are number of non-spinning vertigos also. Now, is this vertigo? Is the dog having vertigo just now? We don't have question answers, but the answer is, anybody wants to tell? How do you, participants can say something if they want to.
So I'll open the chat.
You can ask them to put up their hands.
Or they can write on the chat box.
You can write in the chat box otherwise, yes. So anyway, the answer is this is not vertigo. Why? Because the guy is actually turning around. This is not a false sensation or movement. This is. But will he get? The answer is 3. When he stops turning, he will feel dizzy. All of you all must have played in childhood this game where you go round and round, and when you stop, the inner ear fluid still keeps on spinning, and so you get a false sensation of movement in the other direction. So he will feel dizzy later on. And there are some idiots who have taken dogs and spun them around like that, and then they make them stop, and the dog is ataxic, and they posted those videos on YouTube. So when he is actually spinning, this is not vertigo, but later it is. And these are all different types of non-spinning vertigo. So the person may feel he's swaying, he may feel he's sliding, he may feel he's swaying back and forth or bobbing up and down, or they may just feel tilted to one side. They may feel the floor is tilted. All these are actually vertigo, but this is non-spinning type of vertigo. And when you have a feeling of disturbed or impaired spatial orientation, that is called dizziness. When you combine that with the false sensation of movement, then only you call it vertigo. Okay, what is not vertigo? That is also important to know. So people who feel they are going to faint, that is not vertigo. Who think I can't think clearly, feel dizzy, they call it dizzy. I'm feeling dizzy when the guy looks at a computer screen and doesn't know what to make of it, or he sees a lot of numbers and he's supposed to do calculations and he can't think straight. That also they call dizzy. That is not vertigo. Detachment from reality or just non-specific fatigue, ill health, that is not vertigo. All these are often called, and these are often actually psychogenic or something else, but it is not vertigo. An earlier classification, this is what used to be done. It's called the Drachman-Hart classification. You ask the patient, what do you mean by dizzy? When you say, I'm feeling dizzy, tell me what you mean. Is it vertigo? Is it pre-syncope? Is it imbalance? Or is it lightheadedness? And how do you distinguish that? When the person says everything is spinning around or it's moving, you call it true vertigo. And then the typical precipitant. So true vertigo, the guy will say, I feel dizzy when I'm lying down, when I'm turning, when I look up. That is type 1 vertigo. That is true vertigo. Type 2 is like the guy who stands up suddenly and feels as if he's faint, as if he might pass out. And these are the ones who you should check the standing blood pressure. These are typically cardiovascular causes. And there are other causes also, vasovagal attacks and low cardiac output. But most of the time, most important is postural hypotension. Type 3 is the guys who are feeling unsteady. So they say, I feel imbalance. I feel when I'm standing or walking, I feel as if I might lose balance. They also say, I am feeling chakkar. But when do they feel chakkar? When he stands or when he walks or when he's turning around. And these guys are not having spinning, but they feel unsteady. And there are various causes of unsteadiness. So you start from Binswanger, then gait apraxia to Parkinson's, cerebellar myelopathy, even diabetic neuropathies can feel unsteady and they say, I'm feeling dizzy. Actually, it is they're losing balance. So all these are different causes of imbalance. And then the last type, fourth, is a vague, numb, heavy, light-headed sensation. Now, unfortunately, anybody with the first 3 types who doesn't describe properly can look as if he is type 4. So somebody who has BPPV, but who doesn't describe it as spinning vertigo, you just say, kaitri hote hai dokyat, you may think it is psychogenic. So somebody with mild form or poor history can go off as psychogenic when it is not. Now, this classification has a lot of fallacies because patients don't describe it properly. And like in the first case, you saw the guy with postural hypotension who should have complained, I'm feeling darkness before the eyes. Actually, he said, I'm getting spinning. So you would have thought he's vertigo and he should not be type 2, but he is type 2. So this type is no longer thought to be very important, and they go more by what is the there are various different titrate approach and number of approaches, but if you go by these type 4, you have to first say, is this type 1, type 2, type 3, type 4? If somebody says it is type 1, that is true vertigo. Somebody raised the hand. We'll take them.
I'm allowing them to talk. Should I do that?
Yeah. So some Dr. Rajalakshmi wants to talk. She can talk. So once you have diagnosed something as true vertigo, your next job is it central or is it peripheral? So what do you do? Central is the ones with the deadly Ds. So deadly Ds is what? Diplopia, dysarthria, dysphagia, dysesthesia. All these are the Ds. The peripheral ones don't have these. The peripheral ones look more severe. They look very bad. They are vomiting a lot. They are sweating. The central ones often may look all right. They may have more of ataxia but less of vertigo. And they will typically not have ear symptoms. Though somebody with an ICA territory infarct, you must remember that an ICA territory infarct will have a central cause and yet he will have tinnitus or deafness and ear symptoms. Similarly, most of the ones with peripheral, you expect ear symptoms, but they're not always. So BPPV has no ear symptoms. Vestibular neuritis has no ear symptom. The nystagmus patterns in peripheral are unidirectional except in BPPV, which we'll see. And in central, you may have various types of nystagmus. You can have unidirectional, but you will have sometimes gaze evoke, sometimes upbeating, downbeating. So if you get any different type of nystagmus or you have dissociated, that means abducting eye nystagmus, all these different patterns of nystagmus tell you that it is central. Once you diagnose something as peripheral, then you see, is it lasting seconds? Think of BPPV. If it's minutes, think of a TIA or migraine. If it's hours, think of many years. If it's days, vestibular neuritis. And if it's continuous vertigo, probably psychogenic. All of these 5 types can happen in migraine. So migraine can have seconds, minutes, hours, days, anything. Okay, so we don't go by this anymore. A simpler approach is something which is now called, I'll show that there's a very nice article called Dizziness Demystified. And this one article is by Miriam Welgam-Koller from Sydney. So what she has said, there are 4 presentations, which I will tell you about, and 6 main disorders in neurotology. What are the 4 presentations? We'll see. The 6 disorders are vestibular neuritis, a cerebellar stroke, BPPV, vestibular migraine, Meniere's disease, and the last one is balance disorder. So these are the 6 main things you want to remember. So what are the 4 presentations? You have to think of, is it an attack? The first time attack, then you think of it, that is called an acute vestibular syndrome. Does the person have recurrent attacks? Then you think, is it recurrent positional vertigo or recurrent non-positional, or what is called spontaneous vertigo? When the person has vertigo, he's just sitting, not moving his head, and still everything goes spinning around. So is it first attack? Is it recurrent attacks, positional, non-position? And third, no attack at all, but chronically feeling imbalance. So these are the 4 presentations, and let us see the various causes. In the acute vestibular syndrome, the main cause is cerebellar infarct, which you have to be careful. You have to make sure you are not missing that, though the commoner one is vestibular neuritis. Then the recurrent positional vertigo, of course, most important is BPPV, but you have to remember central. We'll see that. When you have recurrent spontaneous attacks of vertigo, which are not positional, there are 2 main DDs, vestibular migraine or Meniere's. We more often think of Meniere's, but the commoner one by far is vestibular migraine. And then the last one we have already seen, chronic imbalance. So it can happen in various neurological disorders, right from Binswanger's to neuropathy, and also bilateral vestibular impairment. So bilateral vestibular impairment or vestibulopathy, whether it is due to gentamicin or idiopathic, does not present with vertigo. They will have just imbalance. They don't have nystagmus, they don't have vertigo, but they have imbalance and they look like a central midline cerebellar ataxia. So how do you diagnose these 6? Often you can diagnose by history and a targeted examination. Sometimes you need some tests. We'll see those. Maybe audiometry, you may need basic vestibular testing or VNG. So what is acute vestibular syndrome? Let's begin with the 4 syndromes. So the acute vestibular syndrome is the first ever attack, like the boy. He's never had vertigo in the past. He now comes with acute vertigo. These patients are usually very sick and they come to the ED. They'll not come to your clinic because in the clinic, to get an appointment for neurologist is difficult. So you don't get it the same day. So typically they will come to the emergency department with acute onset vertigo. There are 2 main causes, acute vestibular neuritis and cerebellar infarct. And we'll just see some of them in the next few minutes. I want to show one case. This was an 82-year-old male. He's diabetic and hypertensive. He came with acute onset dizziness and oscillopsia. Everything was moving up and down for him. And first time attack of vertigo. His BP was normal, speech was normal, but he had a vertical nystagmus. I'll show you the nystagmus. And mildly unsteady gait. There was no history of vomiting, anorexia or alcoholism. And these are his eye movements. So anybody wants to? I think it's pretty clear. This is upbeating nystagmus. I don't want. Let's not waste too much time. This is upbeating nystagmus. He had an MRI done, which just showed some old chronic ischemic lesions. Then the MRI was repeated at 48 hours because you can miss a stroke in the first one. So MRI at 48 hours was also normal. Now, what would you like to do? Anybody wants to guess anything? What could be the cause? Is this an ear problem or is this central? So, I don't see anybody raising their hands. Anybody wants to guess? Dr. Rajalakshmi, you wanted to speak something, no? I've asked her to unmute. Okay, so I'll go ahead. This cannot be a ear problem. Like I said, in ear problem, it is unidirectional nystagmus. This is upbeating nystagmus. So this is central. Now, what central cause will come acutely? You must think of a stroke. But now we've done a scan and still it is normal. So the important thing you must remember is in a posterior fossa stroke, you must wait up to 72 hours. Sometimes a small infarct is seen only at 72 hours. So when this patient came to me with these two MRI, I said, no, you repeat a scan tomorrow. And they did a scan and what he had was a small infarct here in the pontomedullary junction. So there was a very tiny infarct and he became all right within 2 days with antiplatelets and his nystagmus and everything went away. Okay, but you have to remember that a posterior fossa stroke, the MRI can be false negative up to 72 hours. Don't miss that. And if you clinically suspect it, treat it as stroke and repeat the scan at 72 hours. If even then it is normal, then it is not a stroke. And it doesn't matter whether it's a 3T MRI or what MRI, but the time is important. Okay, then we'll come to acute cerebellar infarct. This can look exactly like vestibular neuritis. So if you have upbeating nystagmus, if you have downbeating nystagmus, if you have gaze evoked nystagmus, obviously it is not a vestibular neuritis. But acute cerebellar infarct can look exactly like vestibular neuritis, and we'll see that. So these are dangerous. So you have to do what is called the HINTS plus protocol. Again, I won't take too much time. Everybody must know what is the HINTS plus protocol. So it stands for head impulse testing. I will show you that head impulse thing. Then nystagmus. So the nystagmus should be unidirectional. It should always keep beating towards one side. If the nystagmus changes direction, it is central. It is not vestibular neuritis. It has to be cerebellar. And the third one is skew deviation. So you look for skew. So the way to look for skew is ask the patient to look at your eye, cover one eye, and then cover the other eye. If there is skew, when you cover one eye, this eye is looking here. So when you cover this and bring down, that eye comes down. So you'll see the eye is going up and down every time you change the cover to side. There are good examples of this in the article, that is the HINTS article. You can look it up on the net. So I won't say. Now, sudden hearing loss is the important one. That's why it is called HINTS plus. So if somebody comes with first time vertigo and has sudden hearing loss also, we will tend to think that this is an ear problem. No. When you get sudden hearing loss for the first time along with the first attack of vertigo, don't think of an ear problem. Think of a stroke. Very likely this is ICA territory ischemia. The ICA supplies the labyrinth and the ICA also supplies the brainstem, and therefore you can get tinnitus or ear symptom or deafness, sometimes like a TI, and then sudden onset vertigo. This is often missed for many years because you think tinnitus, deafness and vertigo, but many years will not come like this with an acute onset. Acute onset hearing loss with vertigo, you must think of a stroke. It can happen some viral illness and sudden onset hearing loss, particularly somebody with risk factors for stroke. Be very careful. So now next we come to acute vestibular neuritis. That's the second cause of the acute vestibular syndrome, that is first time vertigo. So here you will have unidirectional nystagmus. The person will be unsteady, but he should be able to stand without support. He will not have cerebellar signs. Finger nose ataxia nahi, kuch nahi. No diplopia or dysarthria, no tinnitus or deafness. So these patients come with acute onset vertigo, they will vomit, they are sweating, and often they have a lot of vagal discharge and non-specific ECG changes. I have seen number of them land up in the ICU because they are thought to be cardiac. So they're vomiting, sweating, and non-specific ECG changes. And the guy is admitted in the ICU, given all sorts of drugs. And 2 days later, when he tries to get up, then he says, I'm having vertigo. And then the neuro reference comes. So these patients look very sick and they will have this unidirectional nystagmus. His nystagmus keeps beating to the left, whether he looks to the right or he looks to the left. So even when he is looking to the left, the nystagmus is beating. When he looks to the right, of course, it is more. So this is unidirectional nystagmus of vestibular neuritis. This is the head impulse test. So what you do in the head impulse test, you must remember that the function of the labyrinth of the inner ear is to keep the eyes focused on a particular spot when you are moving your head. So even when you move the head very fast, you still can focus your eyes. So one simple test that everybody can do is hold your finger in front and move it from side to side. So you can focus on the finger only when it is moving at a slow speed. But when you hold the finger straight and move your head like this fast, even if you move it very fast, still your eyes can remain focused on that, because as soon as you turn your head to the right, an impulse goes to the right ear, that the fluid turns there, that tells the brain that it is spinning. By 30 degrees you have moved here, so the eyes move 30 degrees to the left, exactly the same degree, and this happens within microseconds. So even before you realize it, your eyes are straight on target. So this is how you test it. You ask the patient, keep looking at me, and you give a sudden jerk to the head. If the patient's inner ear is functioning normally and that loop is working normally, his eyes will keep looking at you. If on the other hand there is some defect in that, then what will happen is the eyes will go there, and then you have told them keep looking at me, then they realize the eyes have gone there, then they give a saccade and correct it. So check out what happens here. We get doing a head impulse to her left, towards the left ear, nothing happens. She's still looking at the camera. Now see what happens when you give a jerk to the right. See. Okay, now important thing is, when you do the head impulse test, the brain is very clever. When the brain realizes that the eye is not moving enough, even while you're doing this head impulse, the eye automatically starts coming in before. So first time you saw good head impulse, second time you didn't see the saccade, third time you didn't see, again fourth time you see. So you have to keep varying, you have to keep the person guessing. The person should not know. This was one of my earlier head impulses. So you can see that there's a big jerk. Nowadays we don't do that. We just do a very little, just slight, and the patient should not know which side you are doing. You do like this, like this, like this, do like this, like this, like this, do like that. So the patient should not be able to guess that now you're going to jerk to this side or you're going to jerk to that side. So see again, jerking to the left, the eye is looking straight at us. But first time when we give a jerk to the right, see what happens. See the saccade. Okay, you have to look at that little saccade, and I'm showing it now in slow motion. First time to the left, the eye keeps looking at the camera. See, the eye has not moved at all. See what happens now in the right. See, the eye was looking there and then she corrected it. So that is the positive head impulse test. So as students, I was told every patient that I used to check his fundus, because only when you have seen about 1,000 fundi, then you start understanding what is a pale disc, what is normal disc, how to see immediately zoom in onto the disc, how to follow the vessels, etc. So same way, now I advise every patient do a head impulse. Whether he comes for neuropathy or whatever, just practice head impulse on every patient who comes, so that you will know what is a normal head impulse and you will start picking up the saccade. It's a very useful sign. Okay. Then there are rarer causes of the first attack. So first episode of vestibular migraine, Meniere's disease, autoimmune inner ear, or first presentation of Imbalance. These are all rare. The two most important are vestibular neuritis and a stroke. Then we come to the next syndrome, that is recurrent positional vertigo. By far the most important is BPPV. Sometimes you have central positional vertigo. And the third one, head motion intolerance, is somebody who has a vestibular loss. He's had a vestibular neuritis in the past. So when he moves his head to one side, he feels slight dizzy just for a second. But that is not really BPPV. That is not positional vertigo. So BPPV I call chakkar number 1. It's the commonest cause of vertigo. It's the most treatable vertigo, and it is very much underdiagnosed. So these are BPPV. The name actually is benign paroxysmal positional vertigo. It's a misnomer. It is not benign. These patients are extremely scared. They are very much disabled, and they are also at risk of falling. So see these guys, how scared they are.
Oh shit.
They are terrified, and you can imagine what happens in a elderly person. You know, he doesn't know. Sometimes he looks up, he feels dizzy. Sometimes looking down, sometimes turning in bed. It doesn't happen every time. You can't guess. And you go to various doctors. Each one tells something. Somebody says spondylosis. Somebody says less blood supply. Somebody says something in the fluid and just gives tablets. And whenever they stop the tablets again, it comes back. So it's very scary and very disabling. This is one place, I used to think epilepsy was the best thing in neurology, where, you start a drug and the guy is all right. But I now think that BPPV is the best, because you can give relief within 5 minutes, almost like magic. And even patients who are ill for months and years, you just do that repositioning maneuver and the guy's vertigo goes away. So it can really make you feel as if you're doing magic. How do you diagnose it? When the person says, doctor, when I look up, when I look down, when I turn in bed, everything spins just for half a minute, that is BPPV. And this is a patient telling this. It's Marathi, unfortunately. So he's saying, when I lie down, when I turn, when I look, it spins. And how long? He says just few seconds. This is one patient where you can do a telephone diagnosis, and I have ventured to do telephone diagnosis also in BPPV, when you may be correct. But history is not enough. You have to provoke an attack and see the positional vertigo and the positional nystagmus. So how do you do it? The best way is to request the patient. The patient knows he has been avoiding that particular movement and the particular position for months. So you tell them, show me what happens. And you should tell them, keep your eyes open when it happens. So this guy is showing us. So you see a typical upbeating torsional nystagmus. This is upbeating and it is torsional towards the lower ear, the right ear. So the upper pole is beating towards the right ear. So this is right posterior canal BPPV. Now it's gone. So this patient had for about 10-15 seconds. Many times it is just 1 or 2 beats and you can miss it. If the person doesn't get it, then you do the Dix-Hallpike maneuver, and what you do is this head hanging, turn the head to 45 degrees to one side, take him down, then turn the head to the left side and take him down. So this Dix-Hallpike maneuver, again, you'll find all sorts of videos on the YouTube. This is one patient. See what is happening here. After a few seconds, she starts getting. But instead of downbeating, upbeating, here you are getting downbeating nystagmus. So this is not a typical posterior canal BPPV. This is a different one. And when you get downbeating, you should think of anterior canal BPPV. But this patient is not even anterior canal. If anybody can tell me what this is, which BPPV is this? Okay, so this is a new variety of BPPV called apogeotropic form of posterior canal. It looks like anterior canal, but it is a posterior canal in a different part of the canal, and that it looks, you get this downbeating nystagmus instead of the typical upbeating nystagmus. Okay, what we do is, I have this video Frenzel. It becomes very easy with this. So we put this goggle on the patient's eyes, and then you can watch the eyes like that when they lie down. So this patient, she's lying on the right and she's getting torsional. So this is right posterior, upbeating, and it is beating like that. This is all sometimes called clockwise, anti-clockwise. What you are seeing is anti-clockwise or beating towards the right ear. The better terminology is torsional to the right. So you got BPPV, don't stop there, check the other side. This patient, we check the other side, and she's got on the other side torsional to the left. So she's got bilateral posterior canal BPPV. See, now you're getting upbeating. So sometimes you can get bilateral BPPV. This patient has bilateral posterior canal BPPV. In the clinic, you do this test. Instead of Dix Halpi, you can do what is called the sideline test, which is what I did in this patient. You just turn the patient's head 45 degrees and fall on one side. So it does the same thing as the Dix Halpi maneuver. If you don't have enough place in your clinic, you can use this sideline test. Now, this is another maneuver called the roll maneuver. This is used when you are suspecting lateral canal. So here the patient is just rolling from one side onto the other, and instead of upbeating or downbeating, he gets a horizontal nystagmus. See what happens. There is no latent period in this. Immediately it starts. So this is horizontal, and again in horizontal nystagmus, there are two types, whether it is beating down towards the ground or beating away. So that is called geotropic or apogeotropic. Geotropic is the one which beats towards the earth, and apogeotropic beats away. Now the important thing is lateral canal is when it turns onto the left, it is beating down towards the left. When it turns on the right ear, it will beat towards the earth on that side, towards the right ear. So it is changing direction whether he sleeps on the left side or the right side. And lateral canal, sometimes it is difficult to diagnose which ear is affected. So there are rules made for diagnosing which sides. Sometimes the ears don't follow the rules. There are various rules and you can read them up later. Okay, so why do you get BPPV? Because the otoconia get loose from the, they are normally these small calcium particles here in the utricle and saccule. They sometimes get loose and then get into one of these canals. If they get into the canal, then every time the patient moves his head, the particles move up and down. And when they move up and down, they stimulate the canal and send a wrong message. So the treatment is get them out and back to where they belong. And that is this thing called canalic repositioning. So you move the particles right from down here up through the canal back into the otoconia, into the utricle. So many times these are the exercises which are given to BPPV patients for vertigo. So they look to one side, look up and turn the head and all. So these are wrong. These are not exercises for BPPV. These are called the Cooksey-Cawthorn exercises. These are for vestibular neuritis. So for BPPV, you do these exercises. These are called the Brand-Daroff exercises. You have to tell the patient to look to one side, fall on one side, wait for 30 seconds, then sit up, look here, fall on this side. And you do 5 repetitions in the morning, 3 times a day. If you do this, 95% patients will get relief in 2 weeks. The problem with the Brand-Daroff exercises is somebody who has severe vertigo will not do this then, because when he lies down, he gets severe vertigo and nausea, vomiting. So they don't do it. And another problem with this is when you do these, when a patient comes to me after doing this, the particles are now spread into all the canals. So sometimes you can get multiple canal because they did Brand-Daroff exercises. But if somebody has mild vertigo, then you should advise this. And this is how we do. We put a VNG on the patient's eyes. This is a different type of VNG that I have. And here it is connected to the computer. So I can see what is happening. So this is the Epley maneuver. You take the patient's head down. We are doing the Epley maneuver. Again, I'm not going to show you the maneuvers in detail because all are available on the YouTube. Look it up. You turn the head 90 degrees to the right side now, watching the nystagmus, and then turn the patient another 90 degrees. So this is the third step, and then you make the patient sit up. All the time you have to observe what is happening to the particle by observing the nystagmus. When you see the nystagmus suddenly change direction while you are doing it, that means the particle is falling backwards. Okay, this patient can't believe the vertigo is gone. So we try to make a sit up. So, this patient used to say that, that when I'm sleeping in the afternoon and the milkman rings the bell and I get up, that is when I get vertigo. So now we had to get a milkman there. So what we did was we told the husband, now you go and stand outside the lab and you knock on the door and she'll imagine it's a milkman. So that's what we did. So now after the bell, she lies down. So this is magic. No, this is what you want to get. Okay, so now not all people with positional vertigo are BPPV. This person had 5 months weight loss, anorexia, 2 months brief attacks of positional vertigo. Somebody tried repositioning. Now what I mean by repositioning into bracket is if you do a repositioning, person should not need any drug if it is done properly. Immediately the vertigo should go away. If the person requires a vestibular suppressant, that means the repositioning has not happened. So anyway, so repositioning was done and he was given vestibular suppressant and went home. Then later he started getting diplopia and fever also. And then he came to me and this is what he had. So when he looks to the right, nystagmus to the right. He looks to left, nystagmus to left. This cannot be BPPV. So this is central, and so obviously we asked for an MRI, and what he had was these tuberculomas. He had multiple tuberculomas, but the one in the posterior fossa in the floor of the fourth ventricle was the one which was responsible for his positional vertigo. Okay, what is subjective BPPV? Somebody who gives a history like BPPV, but you examine him and you don't see nystagmus. And Dix Halpi, you may get symptoms, but no nystagmus. So if you don't have a VNG, sometimes you may miss 1 or 2 beats. But if you have a VNG, and on VNG also the patient says, I'm getting symptoms, but you don't see nystagmus, either this is not BPPV, either it is something central or the person is psychogenic. So these are some patients who had this sort of history, and there was a tumor in the posterior fossa. You can see a tumor in the floor of the fourth ventricle. The commonest cause of central positional vertigo is migraine, but you can get cerebellar tumors, infarcts, etc. Okay, so like I said, how do you diagnose BPPV? The patient says, I'm feeling dizzy, you suspect it, and then you elicit an attack. Sometimes, like in this patient, they don't behave themselves. That's why I told you, type 1, type 2, type 3. This guy is having BPPV.
I get झोपलं तर नाही काय केलं उत्तर बसताना काय होतं डोक्यात एक काहीतरी प्रेशर आल्यासारखं आणि बस.
So he is saying, I get a feeling of pressure in my head, no spinning. See what is happening.
झोपलं की I get झोपलं तर नाही काय केलं उत्तर बसताना काय होतं डोक्यात एक काहीतरी प्रेशर आल्यासारखं आणि बस काय किती वेळासाठी फ्रॅक्शन ऑफ सेकंड और तो विशिष्ट एका राईटला झोपल्यावर होतं का लेफ्टला होतं नाही दोन्हीकडे होतं आणि रात्री कुशी वळता.
So when he gave this history, I knew this is BPPV.
Spinning होत नाही.
No spinning. But when you do his sideline,
तरी झालं डोक्यात झालं की सांगा मला की आता होतं. हां झोपा. डोळे ऐकलं बघा वरती. नव्हतं.
See the nystagmus? He's got a left posterior canal big. He's saying, I'm getting the pressure, but no spinning. And some people are the opposite. Just 1 or 2 beats and then scream and shout. Everything is going wrong. They say, it's like an earthquake happening. So, varies with people. Okay, then we come to the third syndrome, recurrent spontaneous vertigo, not positional. So these are most important is Meniere's or vestibular migraine. And of course, you should not miss vertebrobasilar ischemia. Rarely there is something called vestibular paroxysmia, but I have not yet really seen a case. So the most important ones are Meniere's, vestibular migraine, or vertebrobasilar TIA. Now this is a 60-year-old man, diabetic hypertensive. He had recurrent attacks of brief vertigo, lasting 5 minutes or so, and sometimes with vomiting. No diplopia, dysarthria. Initially, he used to get attacks once in a few days, and then despite aspirin and statin, he started getting attacks every few hours. And this is what is happening during an attack. So the attack, he had that nystagmus, and the attack would last for a few minutes. He had sweating during the attack, and obviously we thought of a TIA, and he did have these multiple infarcts. He had the severe mid-basilar stenosis. So what we did was put him on double antiplatelet, and I pushed up his BP for some time. We gave him a little normal saline and brought his BP up to about 160 or so, and his attack stopped. And this is he was all right. So he's been all right after. Now he's followed for 2 years and he's been okay with single antiplatelet and high dose of statin and maintaining his blood pressure normal. At that time, I had to push up his BP a little bit. Okay. You don't want this to happen. A TI which was missed, and then the guy comes with what we call a locked-in syndrome. He's got ocular bobbing. He had vertigo, and the guy was given vestibular drugs and sent home, and 2 weeks later he came with this locked-in syndrome. He had no diplopia, dysarthria, only vertigo, and that's why it was missed. See, that is ocular bobbing. Eyes are going down like that. Okay, then Meniere's versus migraine. There is no way you can really distinguish, but if you have progressive hearing loss, then it is Meniere's. You don't get progressive hearing loss in vestibular migraine. So if the person has recurrent attacks of vertigo, non-positional, even if he has tinnitus and deafness, it could still be migraine. But if it is progressive hearing loss, then you must think of Meniere's. And vertebral-basal insufficiency we already saw. So not all migraineurs with dizziness fulfill the strict criteria for vestibular migraine. There are all sorts of criteria given and you may miss that. So when somebody has just, I have seen most of the patients who come to me with a diagnosis of Meniere's actually have some other cause of hearing, some other cause of tinnitus, and they have either BPPV or they have migraine. So think of that. So always rule out BPPV if there is positional vertigo in a person with tinnitus and deafness, and ask for history of migraine. So stress, anxiety, neck pain, etc. Look at that. If you have tinnitus which is fluctuating, if you have hearing loss which is fluctuating, if you get fullness in the ear, and if you have recurrent attacks of vertigo more than 20 minutes, then think of Meniere's. There's a lot of overlap. There's no real way to distinguish, and no test can reliably distinguish. Remember, migraine is at least 10 times more common than Meniere's. There is something called ictal nystagmus recording. So like you show ictal in epilepsy, to distinguish between non-epileptic attacks and real epilepsy, if you can record the attack and the EEG during that, you can distinguish. Same way now they are doing ictal nystagmus recording. So you ask the patient to record the nystagmus during an attack, and if you find upbeating or downbeating, it is obviously migraine. If it is only one side, and the side may change direction in migraine sometimes, in Meniere's, if you can record the nystagmus, you may get it. Somebody's come up with a goggle which you give the patient, and you tell the patient, take this goggle home. It has got a video, infrared goggle, and the patient takes it home and records the nystagmus at home when they get an attack. So treatment of Meniere's, actually there is no real treatment known. People have tried low sodium diet, diuretics, intratympanic steroid, gentamicin, sometimes surgery, and beta-histine. Of course, you all know that beta-histine, the big trial of beta-histine, 48 milligrams 3 times a day, also was shown to be equal to placebo. So by a very reputed, the person who promotes beta-histine himself has done the trial and shown that it is of no use. This is called the BMED trial, which has come in the British Medical Journal. So up to 48 milligrams thrice a day of beta-histine is as good as placebo. So always think of migraine because it's much more treatable. You look at the lifestyle, try to cut down salt, of course, and manage the triggers. And sometimes you can give drug. If the person is getting 1 or 2 attacks in a month, then like you treat migraine headaches, you give paracetamol or Naxtom or whatever SOS. If it is only more than twice a month, then you give some prophylactic. Same way, if somebody is getting only 1 or 2 attacks in a month of vertigo, you ask them to take Stemetil or similar drug as and when they get an attack, not more. Okay, then now this is another patient who came with long-standing migraine once in a month or so. He has been having tinnitus and deafness in the left ear for the 8 months. And now he came with 2 days brief attacks of positional vertigo and looking up, looking down, lying down. So obviously when somebody has Positional vertigo, look for BPPV. So even if he's been diagnosed as mania because of the tinnitus, vertigo, deafness, and vertigo attack, because these are positional vertigo, look for BPPV. And sure enough, we did a sideline test, and he has BPPV. There, you get a right torsional. So it is beating towards the right ear, so it has the right posterior canal BPPV. Then the last syndrome is the imbalance as a presenting symptom. So when you get that, all these various causes are there, neurological and bilateral vestibular. So this was an ENT surgeon secretary who had, long-standing imbalance, and this is her nystagmus. When she looks to the right, looking to the left, nystagmus beats to the left. Looks to the right, nystagmus beats to the right. Yeah. Okay. The important thing is this is not symmetrical. See it again. When she looks to the right, the nystagmus is finer, and when she looks to the left, it is more coarse, more obvious. So this is an asymmetric gaze-evoked nystagmus. And when you have an asymmetric gaze-evoked nystagmus, along with tinnitus and deafness, always look for an acoustic tumor. So the patient had an acoustic neuroma. This is called Brunn's nystagmus. This is a better Brunn's again. I'm just showing the asymmetry. Looks to the left, coarse. Looks to right, finer. But it beats to the right. It's not unidirectional. And this person also had a CP angle tumor. This is how to test for the corneal. This is another Brunn's. No, I think the same one. So this is a corneal on the left. On the right, the corneal is absent. On the left, it is present. Remember, when you are doing the corneal, the person should not see the cotton. It should not touch the eyelash. Okay, this is another person. I'm just going to show very rapidly. Rakesh, how much time do you have?
We have time, sir.
Okay, so I'll just show a few cases fast.
Yeah, a lot of time.
Central. So this is a lady who came with imbalance, and she was thought to be psychiatric, and she's moving like this, and she was thought psychiatric until you looked at her eyes and see her eyes. So she has what is called ocular flutter. The eyes are moving like that, side to side. The saccades one after the other. There is no intersaccadic interval. So this is ocular flutter, and it can be idiopathic, but you must look for a paraneoplastic syndrome. It can happen with CA ovary, CA lung, and in children with what is called a neuroblastoma. This another young lady with 3 months progressive unsteadiness, and this is her nystagmus. Yeah. One important examination point here is when you are looking at nystagmus, look at the patient's nose. Keep your eyes on the patient's bridge of the nose, and you will see both eyes. Then you can make out what is happening to the eyes. Both eyes are moving in towards the nose, and this is convergence retraction nystagmus. See again. Keep looking at the nose. If you look at one eye, you will miss the other eye. But if you look at the nose, you see both eyes same time. See what happens when the patient looks up? Both eyes are moving in. And ideally, you should make the patient do a vertical saccade. So you can take a tape. I'm doing a pursuit actually. That is wrong. You should do a saccade. Ask the patient look up, and you'll see the eyes jerk inwards. One way of doing that is take a tape and take the tape down, and the patient starts getting upbeating saccades. So look at the nose, and she had a Parinot syndrome with a tumor at the back of the midbrain. This was another lady with funny symptoms. Again, came from a psychiatrist. She had complaining of breathlessness, dizziness, and numbness in the head on coughing. Now, whenever somebody has pain in the head or numbness in the head of coughing, be careful. This patient does have a nystagmus. Again, you'll see it's a upbeating downbeat nystagmus. More when she looks up, it becomes more obvious. You can sometimes make a patient look to the side and down, and then you'll see the person getting more prominent dysthymus. Sometimes it can be aggravated by looking up. So here you can see both by looking up and looking to the side and down, you see that downbeating. And what she had was Arnold-Chiari malformation. She also had a syrinx. Another young boy with 1 month of unsteadiness, and again he didn't call it unsteadiness, he called it chakkar, and he was receiving drugs for a month. And this is what he has. When he looks to the right, nystagmus beats to the right. When he looks to left, the eyes beat to the left. So when you get this direction changing nystagmus, or what is called gaze evoked nystagmus, this cannot be ear problem. You have to look at the brain, and he didn't have anything else. He had a large pontine glioma. So he just had unsteadiness and this gaze evoked nystagmus. Another boy with recent onset of unsteadiness, he was feeling imbalance while walking, and you can see his walking. He had no finger nose ataxia, eye movements were normal, but he is ataxic when walking. Okay, you can't appreciate it, but he had a slapping gait, and of course his rhombox was positive, and he had B12 deficiency. You can see the very nice MRI showing the posterior column involved. So this was B12. This is another dizzy boy, and he has another sign here. He's complaining of imbalance and dizziness, and what he has is this. Anybody wants to put up their hand? What is this sign? Okay. So this is, okay, Dr. Ramkumar, you can unmute him. Yes, Dr. Kumar.
Facial myorrhythmia, sir.
Sorry?
Facial myorrhythmia, sir.
Facial?
Myorrhythmia.
No, this is not myorrhythmia, something similar. Myorrhythmia is a very slow rhythmic tumor movement, and typically it also occurs along with the eyes movement, and you get it in which disease?
Whipples, sir.
Whipples, correct. So myorrhythmia is a slow rhythmic tremor. This is, you are seeing, see, this is like a, it's constantly moving. Is this hemifacial spasm? There's a continuous movement there. This is not hemifacial spasm. Hemifacial spasm will be like that. So this is a continuous movement wiggling like a bag of worms. This is facial myokemia. And hemifacial spasm is the lesion is outside in the nerve. In myokemia, the lesion is inside the brainstem. So what he had was a plaque. And this guy had multiple sclerosis. There was a plaque in the inside the pons in the root entry zone, way inside. These are two young persons, again with 6 months unsteadiness. They are going around taking Stemetil and Vertin. So you can see this one has a tremor here of the right hand, little bit tremor. And the other boy, what do you see? Anybody wants to say?
Reduced arm swing also.
So he's got reduced, I have given away the thing. He's got reduced arm swing on the left, and he's got a tremor of the left hand. See, the left hand is shaking when he's walking. So both these are Parkinson's. Parkinson's is often missed if the tremor is absent, or if the tremor is subtle, or if the patient is young. You don't think of Parkinson's in these patients. And Parkinson's often will complain of unsteadiness. But they don't say unsteady, they'll say dizzy. So this is an elderly with unexplained falls, and then of course you look for PSP. Side to side is slow, but downbeat, looking down, you can see the round the house sign. So this is PSP. I won't spend too much time on. Another patient with 6 months unsteadiness. Now look at the bridge of his nose if you want to see his eye movements. I'm going to show it a little better now in the next one. Look at the bridge of the nose. See now. Okay, so do you appreciate the nystagmus only in the abducting eye? I'll show it again. This is bilateral INO. The eyes diverge and there's nystagmus in the abducting eye. But you will see it only when you look at the bridge of the nose. The right eye is not coming in, the left eye is showing a little abducting nystagmus. When he looks here, left. So this guy had multiple sclerosis, bilateral INO. This is another girl. Here, of course, the INO is much more gross. You can see it much more. I won't show this. This is a bilateral, again, very gross INO. But here, this is just to show how convergence you can make the person look in. So when she's converging, the eyes are coming in. But when you ask her to look to the sides, there it is not showing. This is bilateral INO, again, it's very severe in MS, bilateral INO. Okay, I'll just go fast over these. Okay, now I think we're coming to the last one. This is a young lady with imbalance, 2 months progressive problem. Initially, she had dizziness and even attacks of vertigo. And gradually, she started feeling constant unsteadiness. And while walking, she says things are moving up and down. So that she has oscillopsia. And this is her gait. She has got gait ataxia and broad-based gait. But when we look at her eye movements, they're quite normal. No nystagmus, saccades, pursuit, everything quite normal. So now you do the head impulse test. Positive to the right, positive to the left. So she's got bilateral head impulse test. She's got bilateral vestibulopathy, and that is the cause for her imbalance. Now, one more test that you can do in people with bilateral vestibulopathy is called dynamic visual acuity. So what you do is ask the patient to read lines. Here I'm giving, I don't have that Snellen's chart. So I just gave her something to read, and then you move the patient's head side to side. When you move the patient's head, their visual acuity goes down because everything is moving for them. Now see what happens with this girl. She can't read when I'm shaking her head. Now she can't read. And as control, we are doing it to the husband. He reads quite easily. So this is dynamic visual acuity. You move the patient's head side to side and they should still be able to read. If the visual acuity goes down, that suggests bilateral vestibulopathy. So these are the symptoms of bilateral vestibulopathy: imbalance, oscillopsia. When they're sitting in a bus, everything moves up and down and they can't read the nameplates in the street while they're going past. Head impulse will be positive. They may have a positive rhombus and dynamic visual acuity. Last one. This is a patient with post-CABG positional headaches. What he's saying is where his head touches, he gets pain there when he lies down. And very funny symptom. So he's having headache more on one side. When somebody comes to me with one side symptoms in one position, I always look for BPPV. So we did his side lying test. On the right side, nothing happens. Okay. Now we do on the left. See, now you can see the torsional nystagmus. And I asked him what happened. He said, yeah, I got headache there. So people can describe it as anything. So the take-home is vertigo can be fun. It can be dangerous if you miss a stroke or a demyelination. It is very treatable, particularly BPPV, but even vestibular neuritis and migraine are. And never miss BPPV, learn to reposition it. And don't miss a stroke in first time vertigo. Learn what is called the hints and the hints plus battery. Okay, thank you. I had some more videos on BPPV and repositioning, but maybe we'll have something like a quiz some other time, and I'll show a few questions, and I'm going to do a Slido and ask you all to participate because just now nobody's putting up their hands. Okay, Rakesh, thank you.
Fantastic, sir. Fabulous. As usual, sir, you really do magic with these BPV patients, sir.
It was terrific, Sudhir.
I think everybody must do magic. Everybody must learn to do these, and it is very easy. It just takes that initial. I think everybody is interested in nystagmus. All neurologists are. Somehow we have outsourced it to ENTs, and ENTs are grossly not able to manage. They cannot take history like we do. They cannot examine the eyes like we do. So reclaim vertigo.
Absolutely, I think.
Especially now that migraine has been realized to be such an important cause, I think you can't let ENTs treat migraine. They are. As it is, I think everybody knows that gastroenterologists treat more migraine than neurologists. So now another chunk should not be allowed to be taken by the ENTs. Migraine is our territory.
Terrific lectures, Sudhir. And for everybody's benefit, Dr. Sudhir Kothari has just published a book called Blind for the Mind. I think it's absolutely worth reading. I'm looking forward to reading it. Yeah.
I think, sir, you'll be giving us a copy. Copied.
Yeah.
Yes, all the.
So I think, Sudhir, a follow-up next week will be great with questions and things. So Rakesh, can we do that? Can we announce that?
Yeah, anybody has questions, they can keep them ready for that day. And I will put up questions like a slide, will show some videos.
Yeah. So I think it will be good for them. They can read for the whole week and then come ready.
Okay.
So next week we will have this slide.
Okay.
Great, Sudhir. Thank you very much.
Just one question.
Yes.
What is the status of thrombolysis in patients of acute vestibular syndrome within 3 hours, and the hints are really suggestive? I mean, they are very, very, very sensitive to pick up the stroke.
Yes, very good question. Now, I have done this in one patient only because they don't reach in time. People are scared to do it. So I have had it, and the houseman sent me the nystagmus and the head impulse and things. And we said, this is stroke and you thrombolize it. And the patient improved. It will take a little, guts. Even I found it scary to thrombolize. So you have to be absolutely sure that the hints is negative. The thing is, in vestibular neuritis on the day 1, the head impulse will be grossly abnormal. After a month, vestibular neuritis you might miss. But on day 1 or day 2, if the vestibular neuritis, if you don't have a head impulse test, it cannot be vestibular neuritis. But Rakesh, what has happened is I have seen number of at least 3-4 patients who came with first time vertigo, occasional headaches in the past, okay, but never had vertigo like this. Head impulse negative, MRI normal. But because the guy had a late night or traveling or something, I thought probably migraine. And then we did migraine. How did I prove it is migraine? After 72 hours, we repeated a scan. And even after 72 hours, there was no stroke seen and the guy improved. So migraine can come with first time vertigo with a negative head impulse. So head impulse will be negative, no skew, nothing, no headache, just acute onset vertigo. So it's a little tricky. So you might end up thrombolizing a migraine, but it's okay. I mean, like we all know that in a mimic, if you thrombolize, the risk of bleeding is not very high.
Absolutely. Thank you so much.
Okay. Thank you. Good night.
Great. So good night all. We meet next week.
Bye.
Thanks, Sudhir, again. Thank you.
Bye, sir.
Mansi, thank you.
Thank you. Thank you, sir. Pleasure.
Thank you, Mansi. Bye-bye.
Thank you, sir. Bye, sir. Good night.